Hello, everybody. Welcome to the Estina Pentax webinar on efficiency and ergonomics in reprocessing workflow. So it's a hot topic because it's not only about cleaning and disinfection, it is also has also to do with safety issues for staff and patient. And we would like to have a short look at the agenda, and I share the session together with Paul César from Pentax. Paul, thank you
Hello,
very
everybody.
much.
Thank you,
Hello.
Ulrike, for the introduction.
Yeah, do you want to introduce yourself?
Yeah, I can do this. So my name is Paul Caesar, and I'm from 2020. I'm working for Pentax Medical, now in the role of Head of Hygiene, Infection Control, and Reprocessing. And you may know Pentax Medical as an endoscope manufacturer, but since a few years, we are also in the field of hygiene and infection control in endoscopy, and also provide some endoscope reprocessing solutions. And before joining Pentax Medical, I have worked more than 25 years in hospital hygiene and infection control in 3 different hospitals, but also as a key lecturer on Dutch nationwide education programs on infection control for nurses and experts, and also worked as an expert sterile medical devices and an expert on endoscope reprocessing. So the last one is a special job task in every Dutch hospital, which is a very good. They went this way already many years ago. And beside these job roles, I was also manager for a few years of an endoscopy ward and including the reprocessing unit in one of these hospitals. So a very warm welcome to everybody who is attending this webinar.
Yeah, and my name is Ulrike Ballenhoff. I'm the Estina Scientific Secretary. I work as a nurse teacher in Germany. Yeah, what is on our agenda? We would like to speak about ergonomics and reprocessing efficiency, and having also a deep look on drying and storage of endoscopes. And therefore, we have 2 esteemed speakers. We will have Dr. Florian Michael from Frankfurt and Arianna Parella from Italy. And they will present a lot of things, and we will introduce them a little bit later. Before we start, you know it, we would like to know who is at the other side of the computer. So who are you, the audience? Are you working as a nurse or endoscopy reprocessing staff? Are you in a managing position, or are you working as a nurse teacher, as a hygienist, a microbiologist? Are you a physician, or are you a member of industry, or someone else? So it's always interesting to know who is at the other end of the webinar, and we have more than 200 registrants, so it's good to know who is on the other side. And I'm sure we will find a lot of friends and colleagues later in the chat. And I would also like to mention that you can use the chat, the Q&A, and also the chat function to ask your questions and give your comments. So we have 36%, we have nurses and endoscopy staff, and 13% of nurse endoscopists and clinical nurse specialists. We have some managers, 3 of them, and 19 colleagues from industry. So that's nice for the beginning. And yeah, as an introduction into the first topic, which will be covered by Florian Michael, we would also like to ask you about how much endoscopes are reprocessed in daily routine in your department. Is it around 1 to 10 or 11 to 20, 21 to 30 endoscopes, or more than 30 endoscopes? Yeah, that also gives us some information about your workload and also the health risks you might face. Yeah, the departments you led, Paul, were, I think, more bigger departments, no?
Yeah, that were typically bigger departments, academic hospitals, university hospitals. So they are always reprocessing more than 80 or over more than 100 endoscopes a day. So that's very big and huge workload, of course. But I know there are also some of these little praxis, private praxis, who may do less endoscopies a day, of course.
Yeah, but it's a nice average here. We have the majority have really bigger departments, with 37% reprocess more than 30 endoscopes. So that is the range you saw. And then the others are, around 20, 23%, 17%. Yeah, it's a nice
it's a nice mixture of
mixture. Yeah, it is.
attendees from different hospitals and different departments and also different practices.
So we have another question. You would like to know which kind of method you use for drying your endoscopes. There are different options available. You can just dry it with using a cloth or a towel. You can also use medical compressed air. You might use your washer disinfectors. In some cases, you need then an additional drying step, manual drying step with medical compressed air. You might use a drying cabinet, or you might use a compressor like the Plasma Typhoon or anything else. Yeah. So it would also good to get your answer on that question. I think in the Netherlands and in the UK and also I think in France, drying cabinets are quite popular. And in Germany, we also have these normal cupboards still available to store an endoscope.
Yeah, you're correct, Ulrike. In the Netherlands, for more than 20 years, drying and storage cabinets, the combined function cabinets, are introduced and widely accepted, and in every hospital where endoscopes are reprocessed. But I guess this also depends on from which country you are, which regulations there are, which guidelines, and also depending on what we said on this small private practice, for example.
Yeah, and it can also be another option, but we will talk about that later. So drying cabinets are used in 46% of the audience, and then followed by the drying after the washer disinfector. And then we also have the manual drying with around 10%, 12, 11%. And the Plasma Typhoon is used, or the compressors are used in 11% of the audience. So thank you very much.
Yeah, I think these were really nice results, and I think this is a nice introduction for our first speaker, of course, because he's talking about drying of your endoscopes. So let me introduce you, Florian Alexander Michael from the University Hospital Frankfurt am Main in Germany, and he will talk about optimizing your endoscope reprocessing with an advanced automated drying technology. So please, Florian, the stage is yours.
Yeah, thank you, Paul, very much for the introduction. I hope you can see the slides.
Yeah, yes, we do.
That's perfect. Then we will start. So this is my conflict of interest statement, and yeah, basically I wanted to start with with an overview of reprocessing, which is probably for this group a little bit too easy, but I will do it anyway. So after finishing the procedure with an endoscope, we start with a bedside cleaning in the room. Then comes the manual cleaning and leakage test. Afterwards, cleaning and disinfection with an EVD, endoscope washer disinfector. Then comes the drying step, and this is what I want to talk about today. And there are different possibilities. There's the manual drying, there's the automated drying, then there's the drying cabinet, and then there's the possibility of reusing the endoscope directly again after the procedure. And then it's followed, or it could be followed, by reuse or by storage. This is also a little bit of a topic today because I think drying and storage goes hand in hand, but we will see in the further presentation. So I want to give a little introduction to the topic. In 2020, Michelle Alpha presented a huge review, which was published in GIE, and she postulated that biofilm maturation is moisture dependent. Speaking, if there's still fluid in the endoscope channel, then this is basically the ground for bacteria to grow and for biofilm to develop. Thereby, inadequate manual cleaning and inadequate drying during storage leads to the formation of buildup biofilm. And this is even difficult for the machine to get rid of. So I want to present a little bit about the current standard of reprocessing. As I showed you, the guidelines from 2018 by Bailnoff et al., they show that there are different possibilities. The direct reuse is not allowed in some countries. However, where I'm from, Germany, it is allowed. So I want to get a little bit into manual drying for 10 minutes and about that study of Barakat et al., which was published in 2019. So they compared basically the manual drying for 10 minutes with a new drying machine that was using laminar airflow. It was medical air, and they had two groups. One was 5 minutes and one was 10 minutes. And what they did was afterwards, they checked how many droplets were still in the endoscope after finishing the drying process. And after manual drying, there were still 4.55 with a deviation of 6.14 droplets in the endoscopes. And after drying 5 minutes with laminar airflow, it was almost none, but still there were some droplets. And after 10 minutes, there were none at all. And then they did a second testing, which was an ATP bioluminescence testing. And that showed that after 48 hours and after 72 hours of storage, there was a significant difference between those groups of manual drying compared to laminar airflow drying. So manual drying seems to be inferior, which was also appreciated by the guidelines in the United States. They say it's still possible, but drying the interior of an endoscope should use a sufficiently prolonged flow of medical air through all accessible channels, ideally simultaneously, which in my opinion is not possible with manual drying, and for at least 10 minutes per endoscope channel for the greatest efficiency. Also, drying in a drying cabinet for 1 hour is possible, and therefore those two options remain in my chart. As I pointed out, direct reuse is possible, but not at the end of the day, and manual drying seems to be inferior. So where are we now? Last year, this paper was published. It basically investigated the drying program of EVDs, and they found out that 10 minutes of air flush was effective at drying the biopsy and suction channel, but not the air and water channels. And hanging had limited effect, being most effective in the biopsy and suction channels again. Therefore, 48% of the endoscopes showed evidence of retained moisture, which we want to reduce. This year, another study appeared by Corey Ofstad, and what she did was she compared basically a new drying machine with a EVD. And she found out that after EVD drying with alcohol and air purge cycles, 100% of endoscopes were still wet. And then she used a new technology, which you can see on the right, which is basically a drying program that is drying all the channels. And after using that for 10 minutes, all the channels were dry. So this is basically the literature that we have on that topic. What we did in Frankfurt, we also performed a drying trial. We started it in, I think, 2020, and after all the organization stuff was finished, we could finally start in 2021. And we formed two groups. One group was also an EVD group where we dried the endoscopes in the EVD. And the other one was a group where a short program in the EVD was performed that you cannot stop. And afterwards, the plasma typhoon was used, which is drying not only by laminar airflow, but using a mixture out of laminar airflow first, to get rid of most of the water, and then a turbulent airflow to get rid of the droplets that are still in the endoscope. And our thesis was basically that drying in group 1 must be more efficient than a drying in group 2. So we want to take a look at the study. We basically performed two studies at the same time. However, they were concepted a little bit different. So in the pilot trial, which is shown on the right side, we had 61 endoscopes. One had to be excluded because it was reused before analysis, and all those endoscopes underwent the guideline suggested reprocessing cycle. But before starting the mechanical part in the machine, we performed randomization, and we either randomized the endoscopes in group 1 or in group 2, as I showed you before. And basically the same was also done in the larger second trial, where 574 endoscopes took place. 8 had to be excluded, and 566 endoscopes were finally analyzed. And I want to present you the results of this trial today. So after the drying step, we measured the residual fluid. And how did we do it? Usually it is performed by using like an indicator paper or something like that to see if there's water or not. But we decided that this would not be enough for us. And since there's at the moment not really an installed technique on how to define if residual water is still there or not, we decided to use a laboratory scale, and we weighted the water that came out of the endoscope. And after that, we performed storage for 3 days in the long group and 14 days, which is the maximum storage period possible in Germany, in the smaller group. And after that, we performed a bacterial sampling to determine bacterial contamination of the endoscope channels. So I want to jump into the results right after showing you the device, obviously. So what we see here is the plasma typhoon. How is it working? It's basically working similar to the EVD. You connect the machine via tubes to the endoscope channels, then you press the start button more or less, and then it is performing the drying for about 1.5 to 3 minutes. It depends a little bit on the endoscope type. I will show you that later. So here are the results of the 3-day trial. Those we presented already at the ESGE days, like 2 months ago, and I want to show them to you again. So we see on the left side that group 1, which is the group with the plasma typhoon, had dry endoscopes after the drying process in almost all endoscopes, and group 2 basically had wet endoscopes. This is similar to the results of Ofsted that I presented to you before. And on the right side, you can see graphically in a box plot how much water was left in there. And you see that almost a gram of water was still in the endoscope after the EVD drying program, and about none water was in there after the plasma typhoon dry. So then we were interested in the type of endoscope. We put in every endoscope that we had in our basically in our cabinets, and therefore we had colonoscopes, gastroscopes, duodenoscopes, bronchoscopes, EBUS devices, and EUS devices. And all but the EUS devices had significantly different amounts of water in there. So it seems to be an effect that accounts for every type of endoscope. EUS was non-significant, but there were only 2 endoscopes in the entire trial. Therefore, it might be underpowered for that endpoint. Afterwards, we also wanted to take a look at colonoscopes, gastroscopes, and duodenoscopes of the different companies, and we want to know if it makes a difference which company you're looking at. And we found out that in group 1, it actually does not make any difference because all endoscopes are dry. In group 2, we had significant differences between the companies, which are shown here in the charts, especially in colonoscopes and duodenoscopes. And interesting enough, the duodenoscopes by Pentax were actually also dry after using the EVD machine, which is interesting. Then I want to show you this chart. This shows basically the difference between the drying time between the 2 groups. So group 1 and group 2 are compared. And you can see that in group 1, it is about depending on the type of endoscope, it's about 6 minutes, a little bit less than 6 minutes up to maybe, let's say, 7 minutes that it takes. And you need to know that the time that was counted is basically the time that was needed in the EVD, which was 3 minutes of drying, and the additional time of the plasma typhoon. So at the moment, it is not possible with our machines to stop the EVD drying program completely. You had to have like a short program run. And on the right side in the table, you can see how long each endoscope type needs to be dried by plasma typhoon. So bronchoscopes and EBS devices, 1.5 minutes. Then the standard devices like duodenoscopes, gastroscopes, and colonoscopes, 2.5 minutes, and EUS devices, 3 minutes. And there was obviously a significant difference to the EVD that took a lot longer. Finally, we were interested in the contamination rate, obviously. And we found that it was about 19% to 18% in both groups, which is non-significant. And if you take a look on the right box plot again, then you see that in the 3 days group with all those endoscopes, 566 of them, we also found no difference, but we also did not find a single endoscope that would go over CFU level, means colony forming unit level, of 10. And if you look at German literature, at least, you will find that up to 20 CFUs are allowed in endoscopes, which are fit to use. So all our endoscopes, no matter in which group they were actually fit to use after 3 days. Then I want to show you the results of the 14 days pilot trial, basically. And you will see the residual fluid and operational time is significantly different, as I showed you already. And what is interesting is the biological contamination rate is also significantly different in this group. So we had 20% in the group 2, which is comparable to the 3-day trial, but we had 47% contamination rate in group 1. However, we also had only one endoscope in the EVD group that had a contamination with more than 20 CFU. So there was only one out of the 60 endoscopes that really had a significant and maybe dangerous amount of CFUs in it. I want to jump to the conclusion and want to show you that, or I hope I showed you that the EVD drying programs by itself is insufficient for all types of endoscopes. Automatic drying machines are convenient, fast, and meticulous. The contamination increases after 14 days in EVD drying compared to drying by an automated drying machine, but not after 3 days, as I could show you in the last slide. And I like that table because it shows a little bit the efficiency part about the drying machines and the drying at all, which is currently available. So I tried to summarize all the literature that we know of at the moment. And we know that the drying cabinets are efficient. However, they take quite a time, which means 60 minutes for every endoscope to be completely dried in the inside. The EVD drying program is the second slowest, 16 minutes in our trial. However, it was also not really efficient. Manual drying was shown by Barakat et al. That after 10 minutes, it seems to be almost efficient. And then we have 3 different drying devices, which is the Dry Scope 8, which was the one used in the Barakat trial, which is using laminar airflow for 10 minutes. The turbulent fluid dryer, which was used by Corey Ofsted, also takes 10 minutes, and both have one thing in common: they use laminar airflow. And what is new to the plasma typhoon device, which takes less time, is that it not only uses laminar airflow, but combines it with the turbulent airflow. And this probably gives it a little bit of heads up, which makes it more efficient, not only more efficient, but also faster. So I want to thank at the end of this presentation, you, the audience, for listening. Obviously, it's always nice to thank your own nurses when you're having a seminar. And especially here with the Istina, I'm really thankful that I'm invited as a doctor to speak here about a really nurse-related topic. And special thanks from my side to Mike Reimers, who you can see on the picture on the left side. On the right, that's me. On the left side, that's Mike, who helped me perform the entire trial, and whose task is it to clean and dry all the endoscopes in our unit. So I'm ready for questions, and I hope you enjoyed the talk.
Yeah. Thank you very much, Florian, for the nice presentation. What really surprised me is that the gastroscope, that the colonoscopes were more difficult to dry than the duodenoscopes. You often thought, oh, the duodenoscopes are the most dangerous endoscopes, whatever, yeah. So, but the longer ones are the let's say the bad boys, yeah.
Yeah, I think it's like you say, the long endoscopes make a difference, and what you also have to see is we basically performed sampling of the channels, so it's still possible that we missed the contamination at the arbor at the elevator, for example. However, this was not the task of our trial. The task was basically to find whether we have a sufficient drying device. And I think one thing is important. We submitted the manuscript also to endoscopy, and I found that there was a problem with the revision because the reviewers kind of had the feeling that the contamination rate is the most important thing here. But in my opinion, you have to take a look at the time because that improves obviously. And the second thing is you need to see if it's dry or not, because it's only one step out of the entire process, right? So if I want to see a reduction in contamination rate, then I need to probably put in less effort in the reprocessing part, because then the drying will have more effect. But if I do a good job at the reprocessing part, then the drying seems not to have such an effect anymore. And this is probably what has resulted in our trial also.
Mm-hmm. And you separate when you sampled the endoscopes, you separated the different channels.
No,
Or did you pool the samples?
we pooled the samples.
Yeah. But did you find any germs of concern, or did you just find, let's say, hand and environmental germs?
Actually, we found only environmental and yeah, as you say, we did not find any germs of concern, and we will show that in the final presentation. Then when after submission is completed, I hope in the final manuscript there is a picture in it that shows all the germs that we found. Also, I left that out because a little bit to the time issue.
Yeah, we have one comment from the audience. A colleague says he or she comes from the UK and says our washer disinfect our AED personnel who sign off any new medical device installation will want a 0 CFU. Is it achievable?
This is a good question, actually. I think the cutoff makes sense. So two things should be you should keep in mind. First, if you find any concerning bacteria, this is a huge problem because you should not find them, basically. The second thing is finding 0 is probably impossible because of the method. And it's a big question if you find 10. Where did the 10 get in? Did it get in during the storage? Did it get in on the way to the lab? Did it get in during the measurement process? You don't know about that. And I think there will never be a method that will find that. So a threshold makes completely sense. And I think it's a waste of money if you try to achieve 0, because it's a little bit a luck game.
Yeah, you cannot. It's even after the washer disinfector, it's a disinfected endoscope and not a sterile one. Yeah, yeah. So that is you cannot have 0, but you do not want to have germs of concern. So no E. coli, no water germs or whatever. Yeah, but you cannot have 0 when you reprocess an endoscope. Yeah, that's correct. Paul, do you have any questions?
Oh, I think this is correct. This is always about the sampling and the sampling method, because when it are environmental or skin bacteria, it can also be related to the sampling procedure. But we should not forget that it could also be a lab contamination, of course.
Yeah.
This is also happening, which is never been discussed, but it is a possibility, of course. Yeah, thank you, Florian. Yeah, sorry.
That really shows also your study, that after 14 days you found more germs, and I know from your department, yeah. So you do not have drying cabinets; you have the normal storage cabinets. And this is still possible in Germany, and it also makes sense. But if you then handle if you an endoscope hang there and you move there, open the doors and so on, you will find more germs after a while. Yeah.
Yeah, but you are sampling the channels, and you are not
you're sampling. Yeah.
catching the
Yeah,
channel.
that's right. That's right. Yeah, from the outside. That's right. That was my mistake. Thank
you.
No.
But
yeah.
It's very
but still,
nice.
I think the point is correct, right? So what we tried to achieve with the trial was also to render real world data, so data that can show how it is in the daily process, not in a lab. And as you said, in Frankfurt we have no storage cabinets, but we have hanging cabinets, vertical hanging cabinets that will be opened and closed every day. And even endoscopes that we put away for 14 days, we kind of took a little bit care of it. So we were hanging them in a cabinet that was not opened every day, but still it was opened. And I see your point, that there might be a little bit more contamination to it, and that is true. But that is probably another discussion, because then you have to discuss how long the endoscopes are allowed to hang away, or how long you can store them. And I think the 14 days trial, which is probably the first I think that is made, shows it quite good that 14 days is doable, and we did not find too many concerned bacteria.
It differs from country to country a little bit.
Yes.
Yeah, and you clearly show that the manual drying is not sufficient. Yeah, and if you dry 10 minutes manually, nobody will stay there in daily routine doing that for 10 minutes. So that is
every channel, basically, right?
Every
so
channel,
you stay there for 30 minutes if it goes wrong.
It's nothing. It's not happening, and it's typically that this is still standard in the US. We discussed it already. Two interesting topics. You touched, Florian, different results for the different brands and types of endoscopes on drying with the washer disinfector. That was quite surprising, I guess.
You mean the different companies, how we found different results?
Yeah.
I mean, it was interesting that that duodenoscopes in the EVD were better dried by for Pentax duodenoscopes compared to the others. However, I think that does not make a huge difference. They are still wet, and I think this is still of concern, and therefore it doesn't work quite well. May I maybe answer that one question in the chat? What is the sample size? Is it 30 for each type of scope? So in the 14 days group, it was 30 for every group. And we had in there about 10 of each type, a little bit more duodenoscopes, I think. No, sorry, a little bit more gastroscopes and colonoscopes. But in the huge trial with the 566 endoscopes, I think we had, there was a wide spread of all types of endoscopes. Obviously, we had a little bit more duodenoscopes, colonoscopes, bronchoscopes, and gastroscopes compared to EUS devices, because those are less used, and it's a little bit more difficult to have them stored on time over the weekend, that they are not used in the morning and we could do the sampling again. So therefore there were a little bit less EUS in there.
So we would like to switch to Ariana's presentation, but before we start with that, we would like to motivate the audience to answer these questions. So do you notice absence due to illness among endoscopy or reprocessing staff, which may be related to suboptimal working posture during the cleaning of endoscopes? So are there any health risks you see? Yes, no, or I don't know. Yeah, we often depends on the size of the sink and the level of the sink, and Ari will speak about that a little bit later. So we often have funny positioning during reprocessing. Yeah. So,
And then maybe also depending on how many endoscopes you are.
or which endoscopes you reprocess and so on. Yeah.
Yeah.
And we saw we have a lot of colleagues from larger departments. Yeah. Okay. Yes. Oh, I don't know. Perhaps, yeah. 28%. That's interesting. But yes, that's around 40%. That's interesting. Good. And another question before starting with the presentation. So on average, how much time do you spend on a manual reprocessing step per endoscope? Yeah, so think about the reprocessing procedure. We have a number of manual steps before that. And so think about how much time you take into account, how much minutes you take into account when you reprocess the endoscope manually before you give it to the washer disinfector. And there are also studies available now who say, okay, the number of minutes also have an influence later on the cleaning efficacy. That's also interesting. Yeah? So the majority say with 40%, 5 to 10 minutes, and then followed by up to 15 minutes with 30%. That's in less than 5 minutes, 11%. So that's and 11% then around up to 30 minutes. That's a lot. Okay, now I have the great pleasure to introduce a very dear colleague, Arianna Parella. She's an endoscopy nurse in the Ramazzini Hospital in Carpi, so Italy, and she has a master's degree in GI endoscopy, and she's the current Estina vice president. So, Ari, welcome, and start with your presentation.
Thank you. Thank you for the kind introduction. I'm going to share my screen. Okay. So good evening, everyone. Thank you for the kind introduction. I'm very happy to be here today and talk about reprocessing workflow and how to make it more efficient and ergonomical friendly. Those are two very important aspects to reach our goal is to have safe endoscope, this is safety for our patients. But sometimes we are so focused on it that we forget the opportunity to find a better way to reach it. So let's now talk about a little bit of reprocessing. And as we all know, reprocessing is a delicate and crucial procedure and necessary to ensure the safety of all our patients. And it requires a series of procedural steps must be meticulously performed. This in order to reduce infection and cross-contamination of both the most critical endoscopes, such duodenoscope or echoendoscope, as well as the endoscope that we often consider to be a lower risk, like gastroscope or colonoscope. So good reprocessing is an indicator of patient safety, which is why we have guidelines, we have documents that told us how to do it properly. We have the EGG position statement on reprocessing, and each country has their own national guideline that we have to follow, especially with the increasing of the multi-resistant organisms that are very difficult to eradicate and very dangerous for our patients. But to understand where we are now, it's necessary to know where we started from. And at the beginning, reprocessing was carried out, let me say, in a very approximate way. We carried out disinfection using glutarate in open containers without worrying about PPE for the operators. And I don't know if you know it, but glutarate can be very irritating to the skin, eyes, and respiratory system. And then we perform some rough brushing, and if we get the chance, use the syringes, a rapid rinsing under the water, and we were ready again to do another procedure. So this was the reprocessing cycle. But then, step by step, through the years, there was an evolution. The first big innovation was the automation of the high-level disinfection. And thanks to that, we recognize the importance of create dirt and clean pathway, dirt and clean areas in the reprocessing room, and also the importance about PPE. If you reprocess, you must wear gloves, high protection, gowns, and etc. Then, with the merge of cases of post-procedure infection, we recognize the importance of create guidelines that allow a standardization of the process. Another important innovation was the introduction of the endoscope wash pump. And with this innovation, we achieve a first partial automation of the manual pre-cleaning. And this is clearly a sign that traceability and automation are important for this process. So we can say that the goal is to have a system that is able to trace the entire pathway because tracking the endoscope assures quality and allows us to identify patient on whom the endoscope has been used, especially clearly when we have positive findings. So this is the reprocessing cycle as we perform it in our daily routine every day. So at the end of the endoscopic procedure, bedside cleaning is immediately carried out using enzymatic detergent. And then the endoscope is taken to the reprocessing area where the manual pre-cleaning begins. First step, leak test, is mandatory. And then we merge the endoscope, we brush and flush all the brushable channel. After that, we continue with a high levels infection. And we conclude with a no less important phase that is the proper drying and storage of the endoscope. As you can see, and as you well know, most of this process is done by humans and is not properly tracked or automated. Especially the manual pre-cleaning is not properly tracked and automated. And this can be a problem because this phase is fundamental to guarantee an effective high levels of infection. And as a humans, we can err, and that is okay. We must be aware of it because we can err for lots of different reasons. We can err for lack of skills, knowledge, and expertise, but also for organizational and management issues. As Jenna told us, as Jenna says in the curriculum that only proper educated and trained personnel should perform reprocessing. This because it's not as easy as it seems. You must know exactly the structure of the endoscope, the anatomy of the endoscope. Only with this knowledge, you can guarantee a good pre-cleaning, a good reprocessing cycle. And beyond that, problem could also be a time problem. We all know this. Too many endoscopes, too little time. No adherence to the guidelines. Health problem associated with the work. A recent study by Chen et al. From 2020 found that the main cause of an incorrect reprocessing is human mistake. And also there is another aspect, a second aspect to keep in mind, talking about reprocessing, that is our environmental impact. We are the third largest producer of waste among the healthcare department. We produce more than 3 kilograms of waste per patient per day. So let's do a quick count in your head. How many patients we meet every day in our endoscopy room? How many procedures we perform every day in endoscopy room? It's a huge number. And the reprocessing process require a large amount of water. Only for the manual pre-cleaning, we need at least 30 liters of water. And furthermore, there is a third aspect that who reprocess know very well. And that is the health problem related to the reprocessing. Because to reprocess an endoscope, you must perform repetitive and forced movement like brushing. And you must stand for a long time. And after 5, 6, or 7 hours, you tend to assume incorrect posture, like leaning with the elbows on the sink. And all of this cause pain to wrist, shoulder, and back. And the fact is that if you feel pain, the effectiveness of your movement is reduced. I found a nice definition. The OSHA, the Occupational Safety and Health Administration, define ergonomics as fitting the job to the person rather than fitting the person to the job. And I think that is essential to understand why ergonomics plays a critical role in the reprocessing process. And if week 3-4 we can reduce the workload and improve the workflow, we can have, let me say, happier, more satisfied colleagues that can be more productive, commitment, and actively collaborate for other needs of the unit. So in light of this, we can clearly say that traceability and automations increase patient safety and reduce patient risk. In addition to this, if there is an option that can save water and waste production, as well improving the workflow, reducing the workload, and blinking an eye to the ergonomics point of view, this would be a very interesting option. And Aqua Typhoon system seems to respond to this need. This system was developed by Plasma Biotics and Pentax, and allowed the manual pre-cleaning to be fully automated and tracked. It consists in a main system to which we connect the endoscope, as you can see in the picture. An aquajet gun necessary to clean the outer surface of the endoscope, and a barcode reader necessary to guarantee the traceability. But the interesting part is how it works. Fit if you're standing, because I'm going to say 3 quite unbelievable things. Because this system uses only water, replace brushing, and allow the manual pre-cleaning in the time range 2 to 7 minutes. I know what you're thinking, because I thought the same thing, but let me explain. The water is first introduced in a pulsed way, followed by a turbulent motion of the air that pushed the water up to 200 kilometers per hour. This is the reason why it can remove all the debris. And with the system, the pre-cleaning phase becomes completely standardized, reproducible, controlled, and very, very intuitive. But I would like to show you a video that can explain this better than me. So we conclude a endoscopic procedure, we perform bedside cleaning, and now we are in the reprocessing room. We take our endoscope and we can put in our sink, or we can use, as you can see in this video, the Aqua box. This is a box specifically designed for Aqua Typhoon. Before we start, we need to scan the barcode of the operator, clearly, and the barcode of the endoscope. And after that, we are ready to start. First thing to do is always the same, is the leak test. Leak test is mandatory. We must know this, because if we skip this phase and there is any small breaks in the endoscope and we start cleaning it, we risk irreparable damage to it. So, and when perform the leak test, remember to do the up and down and right and left movement. They guarantee a very good leak test. A little things to keep in mind: if you are using your own sink, remember to protect the operator from being splashed using a plexiglass or a plastic transparent cover. As you can imagine, the Aqua box is very useful because you can work directly on the endoscope and prevent the operator from being splashed. Okay, the leak test is good. We can start cleaning the endoscope. So we start cleaning the outer surface of the endoscope. We take aquajet gun and we start from the bottom section and then from the cloche to the tip. Clearly, the proper position of the endoscope is extremely important, because you have to reach each part of the endoscope and you have to clean carefully every part of the endoscope. A nice thing is that everything is predefined by the system and cannot be changed by the operator. You cannot change the amount of water or the time necessary for any phases. Okay, this phase is already finished. We can start cleaning the channel, the brushable and no brushable. So we connect the endoscope in the very classical way. And from now on, the system works on its own. The operator is totally free. The one thing that I would like to show you is the power of the water. As you can see, in a few seconds, at the beginning, it's not so high, but then second after second, it increases. And we have to imagine that this power goes through very small channels. This is why it can remove the debris. And you have just seen that you don't immerse the endoscope, you don't brush or wipe the endoscope. So all the repetitive and forced movement are no longer done. Clearly, at the end of this phase, in the reality, some organic residue may have been deposited on the outer surface of the endoscope. So we cannot immediately proceed with high levels of infection. Before that, we need to clean one last time the outer surface of the endoscope using aquajet gun. So we disconnect the endoscope and we repeat the same phase again. So we take aquajet gun, we start cleaning from the barbell section and then from the cloche to the tip. After that, we are ready to proceed with a high level disinfection, as you can see in this video. So a very quick overview. The traditional manual pre-cleaning needs 15 to 30 liters of water. You must use chemicals. You must brush your endoscope. The cycle time lasts 10 to 15 minutes and is not fully traceable. With Aqua Typhoon, you need 4.4, 4.6 liters of water. You don't use chemical. You don't brush your endoscope anymore. The cycle time lasts 2 to 7 minutes and is fully traceable. So it's very good for the workflow, reduce the workload, and it's also very good for the ergonomics aspect. But there is another aspect we discussed about, and that was our environmental impact. So initial studies were carried out, and the results shown that we have a reduction in water consumption more than 70%, a general cost reduction more than 80%, a waste reduction more than 90%. But just look at the first table, slide number 2, at the bottom, we can see that the total waste production per year is around 1,600 kilograms compared to 56. The total water consumption per year is around 210 cubic meter compared to 31. And the total cost per year is around 85,000 euros compared to 10,000 euros. It's a big, big difference. And we found the same result at the slide number 3. So we can clearly say that it's also good for our environmental impact and from the economical aspect. But at the end, what we want is to have a safe endoscope. What we want is the safety of our patients. So clearly, microbiological and protein tests were also carried out. And the results show that in all cases, with any type of endoscope from different companies, the result was always the same, always under the target level. So we can also say that it's safe for our patients. It's simple, it's fast, it's sustainable, cost-effective, shortening the workflow, definitely, standardize the process, is traceable, and it's very, very good for the ergonomics. So is this a game changer? Or your experience or your studies will answer to this question. What we can say now is that clearly reduce the time needed for pre-cleaning and makes pre-cleaning fully traceable and automated. Optimize the workflow and reduce the workload for the operators and also the risk for them due to the absence of potential toxic products through contact and inhalation. And reduce water consumption, waste production, as well the total cost. Sometimes we just have to think outside the box. And I know it's not easy. And I know sometimes the box we are in can be very warm and comfortable and we really like it. But a very dear colleague once told me that when you look at something and you think that it's perfect, no longer needing improvement, you have failed because you must be never satisfied. Evolution is necessary to reach the excellence. Thank you.
Thank you very much, Ariana, for your nice presentation. Are there any studies available at the moment showing the level of efficacy?
Sorry, pardon, you can go on.
Yeah. Are there any studies available comparing the brushing and the plasma typhoon at the moment? Aqua typhoon.
There are some
Paul can
studies.
also answer the question.
Yeah, actually, you can also better than me.
No. Yeah, thank you for the question, Ulrike. Yes, there is one study which is now finished. They compared the traditional brushing of duodenoscopes with the brushes, and they compared it with the Aqua Typhoon. They said the results are good, but they need to have the time to write it down. It's just finished the sampling, so I think it will be in about a few months that the results will be published, and we have some studies in the pipeline.
So, and the results are comparable, or you can't not say anything at the moment?
No, I cannot say anything at the moment, but
Good.
they said, okay, the results were good.
Oh, good. Okay, so keep it with the good. So we will wait for the results. Yeah. So there are a number of questions in the chat. One is you put the box of the plasma typhoon near to your sink, but is there any drainage you put down because you work with water? So is there any drainage?
This video is not from my hospital, but when I tested it, I don't have a system of drainage because the amount of water is not so high, and the box is very, very not heavy, so it's very easy to clean inside, and then you are ready to go again with another endoscope.
But you work, yeah. Pardon?
There is a drain. There is a drain you can put in the sink. Yeah.
Okay.
Yeah.
And the total time the machine needs is about how many minutes?
7 minutes. It depends from the endoscope. Clearly, a duodenoscope is longer than a gastroscope for obvious reasons, but from 2 to 7 minutes. 7.
Okay. And again, a question was, do we need any detergents? No, we don't need any detergents. Huh?
No, not with Aqua Typhoon.
Yeah. There was another question. What do you mean by validation path? Did you mention that? What level of reduction does Aqua Typhoon trying to achieve?
When I talk about the target level, I think that this was the questions. Maybe I want to read it.
So usually we reduce how much log steps in a cleaning step? Around.
Oh, it was on the protein residual test.
Yeah.
Yes,
so
it was both
no
the
log reduction. It was on the protein residual test, and so yeah, no one is doing the microbiological sampling after the pre-cleaning.
No, but it's a protein, yeah.
But the protein, yeah, they meet the standards. Yeah.
Yes, and also with the protein, they did a study to compare pre-cleaning with Aqua Typhoon and without, using swab to test if there are the amount of protein inside of the channels. So yes, this was if this was a question, this is the answer. The microbiological tests were carried out at the end. So at the end of a complete processing cycle with Aqua Typhoon and a complete reprocessing cycle without Aqua Typhoon, and compare the results.
Okay, there's another question. What does the difference in mechanisms of action of cleaning by Aqua Typhoon or ER cleaning? So the Aqua Typhoon is replace a manual reprocessing.
Yeah,
only.
And not the washer disinfector.
Absolutely not. Absolutely not. It only transform the manual pre-cleaning in an automated pre-cleaning, but you must always continue to perform high levels of infection. It's a totally different device.
Yeah. I think the next question is one for you, Paul. Have all endoscope manufacturers signed off on this program, on this product to be compatible with their scopes?
Yeah, that's a good question, of course, but we didn't receive any letters from our other brands of endoscopes, but we showed it is compatible. We showed it in these hospitals in France, for example. They used all brands of endoscopes and types of endoscopes, and they are using Aqua Typhoon all for a long time, with good results, of course.
But if I have at the moment Olympus or Fuji endoscopes, I can also get the adapters for these kind of endoscopes.
Yeah. Yes, you can. Yes, you can. We tested on the Olympus and the Fuji, and we had different adapters.
How do you clean how can the Aqua Typhoon be cleaned in between the endoscope cleaning steps? So do we have to change, let's say, the tubes, or do we have to clean the box? What do we have to do in between?
We can clean, clearly we can clean the connectors, of course, because some organic residue may have been all over the box. This is, and we can do the same thing, like we clean all our stuff. If you remember at the beginning, I said that the bedside cleaning with enzymatic detergent remain. So we can use something similar to clean the box and the tubes.
Yeah. So
it's necessary. We cannot risk cross-contamination through all the endoscopes.
So we clean the Aqua Typhoon the same way like we clean the sink, and the other cleaning adapters we also use in manual cleaning. So that is the same procedure,
yeah.
No?
Yeah. It should be the same procedure, yes.
It should be the same procedure, yes.
Yeah.
Yeah, if you, both of you, Florian and Ariana, with your experience, and you have a look at the moment at the reprocessing areas, so the dirty area, does the construction, the way how the reprocessing area is arranged at the moment, this has to be changed when we establish this kind of products? I do not need a sink, or can I combine the sink with a covering and then use the machine of the Aqua Typhoon? Or do I need special space for using the Plasma Typhoon? So what has to be taken into account when you see the design of the reprocessing areas at the moment?
If you don't have to rebuild a new reprocessing, you can clearly stay with your own conformation with your sink. You just need a little bit of space next to it to put the Aqua box. But if you think you can also use the Aqua Typhoon, that is a very small device, is very small product, so can clearly put next to the sink, and you can use your own sink if you want. If there is, it is not a big reprocessing room, for example. We just also how big the reprocessing area is important, because if you work in a very small reality and you cannot change all the reprocessing area, this is to keep in mind.
Maybe I can add a picture to it.
Yeah.
If that's okay. I gave a presentation also on Aqua Typhoon, like I think last year, and maybe you can see that at the moment. So this is in Frankfurt. This is our
the dirty area, no?
The dirty area, right? And in the back you can see in the red box, this is the Aqua Typhoon. We had it for testing, and there you can see it fits in quite okay. We used one of our 3 sinks in order to install it, and it worked quite fine. So you could choose now either to use all 3 sinks for the Aqua Typhoon, or as we did, we used one and had 2 more sinks for the manual cleaning as we're used to. So that worked quite good.
But we need a covering, no? That I think that is what Ariana showed, that we have a lot of water splashes, no?
Yeah, yes, it's mandatory to protect. I don't know Florian experience, but I think that is quite fundamental to protect the operator.
Yeah, I think what is quite interesting is that you can either use the Aqua Typhoon, or you can sorry, the box of the Aqua Typhoon as you presented it, or you could also use a sink and put like a glass over it, which is also possible to use, and I think might even be a little bit better idea if you have already installed all the sinks. It might be a little bit less ergonomics, since we're talking about ergonomics also today.
A lot of endoscope reprocessing areas already have a covering over the, what is it? How can I say it in English? Ein Spritzschutz, Paul, hilf mir mal.
You have this covering above the
splash
sink,
protection.
Splash
Splash
protection,
protection, thank you. For at the sinks, yeah, and this can also be used. And if we then close it, I think that is also possible, no?
Yeah, this could be an option.
Yeah.
It's also depending how you handle the aqua jet, of course.
Yeah.
In the direction which you use the aqua jet is also makes sense, I guess. And jump in on the question also, redesigning your reprocessing area. We see a lot of these large sinks of about 2 meters now. Why? Because you have to stretch the endoscope. Why? Because of the brushing. You cannot brush a coiled endoscope. And now we see with this kind of device, you can redesign your sinks in your reprocessing room. You don't need these long sinks anymore.
Another question. So we get rid of the brushing, and we can also get rid of the additional rinsing before putting the endoscope into the washer disinfector. Yeah. So that are the 2 steps, I think, which can be replaced. And with the drying, so with the Plasma Typhoon, we can get rid of the drying cabinet if we want to, and can replace it as well. So that are the 2 options. No? Any further comments? Did we cover everything? I think we did. Then I would say thank you very much to Ariana, ladies first, and to Florian for the very informative presentations. Thank you very much, Paul, for being my co-moderator and supporting us with some inside information. So that was really a pleasure. And I would like to close the webinar with announcing some events. Make sure that you get your tickets to come to Vienna. We have the Esgina conference here at the UEG week, and I also wanted to make sure that you are aware of the ESG days, which will take place in April in next year in Barcelona. We will have the next webinar in September. It will be on a totally different topic about communication. And then I can just give you, I just can wish you a nice holiday time, wherever or whatever you want to do. So again, thank you very much to the audience, and thank you very much to you for joining us. Yeah.
Thank you so much.
Yeah, thank you very much.
It's always a pleasure.
Yeah. And have a nice evening to everybody.
Thank you so much.
Thank you.
Bye.